Sir, may I start the session? Thank you, sir. Good morning. Welcome to today's auspicious program in National Institute of ENT. And I am Dr. Muhammad Mahbubullah, working as Assistant Professor of Radiology Imaging Department of this institution. And I am going to start today's presentation with the permission of the chair. And my topic is head neck radiology, larynx. First, why imaging? Understanding the anatomic concept, review of laryngeal pathologies, diagnosis, staging of the disease, and management plan. And anatomy of the larynx. The larynx is a system of mucosal folds supported by cartilaginous framework. The upper edge of the epiglottis represents the most superior limit of the larynx. The epiglottis is the anterior boundary of the entrance into the larynx, anteriorly to small sulci, the belliculi. Anatomy. How we divided the larynx in radiological division of the larynx. First, here the EROA. We first identified the heart palate, the posterior most part of the heart palate. We draw a horizontal line from the heart palate. Above the line, this is nasopharynx, and below the lines, it is oropharynx. And then we identify the heart palate. The posterior superior most part of the heart palate, we draw a horizontal line from the posterior superior most part of the heart palate. The upper portion is the oropharynx and lower portion of the laryngopharynx and larynx. The three parallel structure, true buccal fold, false buccal fold, the ventricle organize the larynx into three regions that are supraglottis, glottis, and subglottis. Here, T1 MR image and EROS 3D CT view. We see here is the ventricle, here is the laryngeal ventricle, the EROA. Above the ventricle is the supraglottis, and here is the true buccal fold. And above the ventricle, it is false buccal fold. It is true buccal fold. It is the glottis, and from true buccal fold up to the lower border of the cricoid. From true buccal fold below is subglottis, and here is the laryngeal ventricle. Above the false buccal fold, this is supraglottis, this is glottis, and below the area is subglottis. Same image, the supraglottis, glottis, and subglottis. Below the true buccal fold is subglottis. And same image, sagittal view. Here we identify the hyoid bone and draw a line perpendicular to the horizontal part of the hyoid bone. The supraglottis and true buccal fold area is glottis, and below is subglottis. And now we go for axial images. And axial images, we first we draw a section at the level of the hyoid bone. Here you see the uppermost part of the larynx. It is epiglottis. The midline structure is median glossoepiglottic fold, and two EROA is air density areas are belliculi. And here is the it is T2 MRI. Same, the supraglottis area, the belliculi, epiglottis, and the EROA. And now we go at the level of middle part of the supraglottis. Here we see this is free portion of the epiglottis. There is the fixed portion of the epiglottis, and these are the paraglottic space. These are two pyriform sinuses and posterior pharyngeal wall. And below, here also the ariepiglottic fold is started to appear. And below this level, at the lower part of the supraglottis, we see the ariepiglottic fold, the paraglottic spaces, and lower part of the pyriform sinuses. And then at the level of glottis, how we identify glottic areas in CT scan. First, we see this is the circle area. This is the joint of cartilage. This is cricoid and arytenoid. Cricoarytenoid joint. Here is the cricoarytenoid joint. When cricoarytenoid joint appears in CT scan, it is the glottic area. And below the area, when there is a thyroid gland is appearing and there is a semicircular or circular ring of the cartilaginous ring, this is subglottic area axially. And component of supraglottic component are epiglottis, epiglottic folds, and false buccal folds. Here is the graphical representation of the supraglottic area. We see the epiglottis, medium glossoepiglottic fold. These are the belliculi, and same in the CT scan. The epiglottis, median glossoepiglottic fold, pre-epiglottic space. This is the epiglottis. This is the midline structure, is medium glossoepiglottic fold. This is epiglottis, free margin, supraglottic. Below this level, we also see that here is the epiglottic fold started to appear, the pyriform sinuses and posterior pharyngeal wall, and these areas are pre-epiglottic space, and it is the fixed portion of the epiglottis at this level. And below this level, we see the epiglottic fold, the pyriform sinuses, posterior pharyngeal wall, and pre-epiglottic space. And most lowest part of the supraglottis, here is the epiglottic fold, pyriform sinus. And next, the glottic part will arrive. There is the glottic part of the two buccal fold, anterior commissure and posterior commissure. Graphic representation. So the cricoid cartilage, this is cricoid cartilage, this is arytenoid cartilage, this is cricoarytenoid joint, and this is the glottic, the buccalis and thyroarytenoid muscle. And in CT scan, we identify the cricoarytenoid joint, and the areas is glottic area. Subglottic includes undersurface of the true buccal cords to the lower border of the cricoid cartilage. And CT appearance, in axial CT appearance of the supraglottic, glottic, and subglottic areas. Here, supraglottic area airway, we see the epiglottic fold and pyriform sinuses. Behind, there is no cartilaginous structure. When we go to glottic area, we do not see the pyriform sinuses or epiglottic fold, but we see the cricoid cartilage here and arytenoid cartilage here forming the cricoarytenoid joint, the glottic area. And below, we see a circular ring, cartilaginous ring, and laterally we may found the thyroid lobe of hyperdense lobe of thyroid. Then we can say that it is subglottic area. And in coronal graphic representation, the ventricle, above it is supraglottic area, the true buccal fold, it is glottic area, and below is subglottic area up to the lower border of the cricoid cartilage. And also same in the CT scan coronal, this is the laryngeal ventricle, this dilated part of the laryngeal ventricle, this is false buccal fold, this is supraglottic true buccal fold, this is glottic area, and below this up to the lower border of the cricoid cartilage is subglottic area. Now I am going to laryngeal carcinoma. First, glottic tumors. Carcinoma of the true cord is the most common form of the interlaryngeal growth. It presents early with hoarseness, is easily assessed by direct examination, and has the best prognosis. However, involvement of the anterior commissure with spread of the other side worsens the prognosis. Here is a small lesion. Here is a small lesion. The cricoid cartilage, thyroid cartilage, the glottic area. Here is a small lesion in right true buccal fold, small elevation. Here is also, here is the small elevation. This is non-contrast and this is contrast scan, CT scan. And coronal scan shows here is the small lesion, the true glottic lesion, only involve the right buccal fold. And here is the upstage lesion of the glottic carcinoma. We see a lesion in the anterior commissure, the lesion eroding in the anterior part of the both part of the thyroid cartilage, and there is a large extension of the lesion in the preglottic area. Supraglottic tumors, these are best assessed endoscopically, but may be shown by their ragged appearance on the plain lateral radiograph. Growths arising in the bellicula or in the ventricle of the larynx may apparent on endoscopy or confirmed by biopsy. CT or MRI may be helpful by demonstrating invasion of the base of the tongue, obliteration of the ventricle, and erosion through the thyroid cartilage into the thyroid gland. Supraglottic cancers tend to spread directly into the upper deep cervical lymph nodes. Here, the laryngeal ventricle, and here is the mass in supraglottic area. In CT scan, we see this is the laryngeal ventricle, this is true vocal fold, and lesion is above the true vocal fold. It is supraglottic tumor, but it extends upwards up to the epiglottis and bellicula. And also there is the small paralaryngeal extension. There is a tumor of upper stage of supraglottic tumor. We see both side of the right and left side of the supraglottic tumor. There is into the anterior part. The same here is the piriform fossa. This is the first upper limit, in upper part, and this is little bit lower part, the lesion. And in sagittal, we see a large lesion into the supraglottic area. We see in left side there is a large lesion into the supraglottic area. And lesion with supraglottic and glottic extension. Here we see a lesion in the supraglottic. Laryngeal ventricle is not identified, and the lesion extends up to the cricoid cartilage, and this is supraglottic and glottic. Here we see the supraglottic area, and here is the glottic area, the glottic mass and the glottic mass. Also in sagittal, a large mass extended from the piriform sinus up to the true vocal fold. And disproportion tumor and lymph node, a small supraglottic mass in the thyroid level, hyoid cartilage level, hyoid bone level, and we see there is a large necrotic different sizes lymph nodes in both sides. Subglottic tumors, these are the least common type. The undersurface of the cord is the usual site of the origin, and subsequent involvement of the vocal cord occurs. This region is difficult to assess endoscopically. MRI and CT may help by showing asymmetry. CT is to show invasion of the cartilaginous skeleton of the larynx by the tumor. And here you see a graphical subglottic tumor. This is the true glottic fold. Below is subglottic tumor up to the lower border of the cricoid cartilage, and we see in axial contrast CT scan a tumor in the subglottic area. There is a circumferential cartilaginous ring, so it is subglottic area, and also we find the thyroid lobe there. It is subglottic area. The lesion tends to invade the left lobe of the thyroid gland. Another subglottic mass, we see there is a circumferential tracheal ring. There is a mass in the right side of the tracheal wall. Also there is, the lesion involves the right lobe of the thyroid gland. There is some necrotic lymph nodes at level 4. Then staging of the tumor. T1 tumor limited to one subsite of supraglottis or glottis. T2 tumor invades mucosa of more than one adjacent subsite of supraglottis or glottis, or region outside the supraglottis, that is mucosa of base of the tongue, bellicula, medial of the piriform sinus. 3T tumor limited to larynx with vocal cord fixation or invades tissue beyond the larynx, there is a post-cricoid area, epiglottic tissue, paraglottic space, or minor thyroid cartilage erosion. T4A tumor invades through the thyroid cartilage or invade tissue beyond the larynx. There is a trachea, deep intrinsic muscles of the tongue, step muscle, thyroid gland, and esophagus. And T4B tumor invades prevertebral space or encased carotid artery or invades mediastinal structure. Here is a T1 tumor, a small tumor. I saw it previously, a small lesion in the glottic area. It is a T1 tumor. Another tumor involves both sides of the supraglottic area. Okay, this is a T2 tumor. Here is a supraglottic glottic tumor, the supraglottic, the glottic involved, but we see there is a subtle erosion of the right lamina of the thyroid cartilage with mild paraglottic extension. This is a T3 tumor. We see patient has a tracheostomy, and there is huge air density area within the cervical tissue plane. The patient developed subcutaneous emphysema during tracheostomy. And we go for T4A tumor. There is a large tumor in supraglottic region, supraglottic glottic region. There is the gross erosion of the right thyroid cartilage and gross paralaryngeal extension. Here is the gross paralaryngeal extension and right thyroid cartilage is eroded. This is a T4A tumor. And this is also a T4A tumor. The supraglottic glottic tumor that erodes the right thyroid cartilage extension into the right paraglottic area. There is the multiple enlarged lymph nodes at level 3. Here is the enlarged lymph nodes, and there is the paraglottic extension of the tumor. And T4B tumor, when we see, so I called it is T4B tumor. It is a, here is the tumor location in supraglottic area, in subglottic area, in subglottic area. There is the tracheal ring, and subglottic area, there is the extension of the prevertebral soft tissue, large soft tissue mass in prevertebral region. And here we see the lesion involves the thyroid, left lobe of the thyroid gland. It is T4B tumor. Then lymph nodes, N0 cervical lymph nodes not palpable, N1 palpable nodes unilateral not fixed, N2 palpable nodes bilateral, contralateral or midline nodes not fixed, N3 fixed cervical lymph nodes. And first we see a tumor, a supraglottic glottic tumor. There are the lymph nodes, unilateral lymph nodes, that is N1. That is also a N1 lymph node, supraglottic glottic lesion. There is lymph nodes in left side. There is the left sided cervical lymph nodes. This is also N1. Here is the cervical lymph nodes in left level 2 and 3. It is supraglottic N1 lymph node. And when we see supraglottic glottic mass with bilateral necrotic cervical lymph nodes, here are the lymph nodes, large lymph nodes, here are the lymph nodes, and also here are the lymph nodes. This is a N2 disease. And here we see, I saw the lesion previously. There is a necrotic lymph node, a small lesion in the hyoid level, and there is a large necrotic lymph nodes appears invades the sternocleidomastoid muscles, also the internal jugular vein. This is N3. And this is end of my presentation. Thank you for patient hearing.